Thank you very much for the lovely introduction, Paul. All of it's untrue, of course. I want to thank Professor Gajewski for the introduction. I want to thank Jan and Paul for many years of education. So some of the concepts I'm going to present today are actually the founding foundations are relayed by Paul in particular. So this is my disclosures here. I also work for a clinical research organisation, so I have lots of pharmaceutical interactions, but I don't think any of them are significant. So my talk today covers 6 different areas. I'm going to concentrate particularly on areas 4, 5 and 6, endoscopy, chemoprevention and eating and exercise. The methods I used for my talk today were a PubMed keyword search, looking at national guidelines, particularly NICE and Cochrane. I used to be a National Institute or clinical advisor. I used AI-assisted ChatGPT 4.0. The endpoints I used for my searches were gastrointestinal cancer. I haven't looked specifically at hepatobiliary cancer, although I'm happy to pick that up in questions later. I looked at mortality in cancer for preventions as the endpoint of my studies. I had a very clear steer from Professor Gajewski. He wanted clear practical guidance that people in the audience could take away with them. Now, I just want to say that gastrointestinal cancer, we know that it's going to increase over the next 25 years. If you look at the number of cases currently, 10.1 million at the start of the millennium, and moving up here to 35 million. And although there's an increase here, there's a small increase in the amount of cancers cured. So we've gone from 61% of cancers that are uncured, and we decrease that down to 52%. So just over a majority of cancers are still uncured. So we're making, it looks like we'll make some progress. The other thing I want to point out here is, in fact, this demographic, which is very worrying. So if you look at the amount of cancer increases, particularly in the younger age groups, under 50 and under 40 in some too, versus the demographics in older, you can see that there's a plateau or a decrease in older individuals, where in younger individuals there's actually a proportional increase. And the significance of that is the massive life years lost is going to outweigh that. So although the problem looks like in some ways that we're tackling cancer and preventing more deaths, we still haven't got to the 50% line. And secondly, more young people will be getting gastrointestinal cancers with life years lost. So if I go on to the first part of my talk out the 6 here, if we look at the modifiable factors, we know that in gastrointestinal cancer, pretty much all the expertise and reference sources indicate that 45% of cancers have modifiable risk factors. So theoretically, if you did everything right, you could prevent up to 45% of your cancers. And I'll come on to what these are. I've put social status down. Obviously, there's a strong argument of whether that's really modifiable or not. And then there's a non-modifiable factors here, which are age, sex. Males get more gastrointestinal cancer than females by and large, family history and ethnicity. So if we go into the modifiable factors here, you can see their relative risk to cancer and cancer mortality and incidence here, with tobacco smoking being by far the biggest modifiable factor that can be changed. So it's really important to emphasize that actually tolerating zero smoke, even passive smoke, has been shown in studies to actually be a sizable risk factor. If we look at excess weight, alcohol consumption and poor diet, I'm going to tackle those elements later on in my talk. So if you're going to look at modifiable factors, here's 2 papers from the Lancet indicating that this is a risk of alcohol consumption. And I apologize for spoiling people's Saturday evenings. But in fact, if you look at this, this is updated by this research group every 2 years. And in fact, this is the safe level thought to be safe level of alcohol consumption. And every 2 years, this purple line gets bigger and bigger and eats into this line here. So you can see there's a wide overlap. Some people may have a safe level of alcohol consumption here of 3 units per day, but for a vast majority of people, it's more like 1 unit per day. In fact, over time, it's quite likely that this, if you want to be really safe about alcohol consumption, so get some of the benefits, because there's meant to be a very small benefit here, it probably is no more than half a unit a day on average, so 3.5 units over a week, which is equivalent to a third of a bottle of wine. So that's just food for thought. So make sure that if you're going to change your modifiable factors, it's got to be low enough to make a difference. And if I were to show you the cancer risk factors rather than the overall mortality figures, in fact, cancer risk factors certainly kick up here around about 3 units per day, and probably 2 units per day. There's actually the risk factors for alcohol rather than overall mortality increases earlier in the curve. The second issue about smoking alcohol, so if you look at intervening in people who smoke, in fact, this is the risk base on people who smoke, but actually this is the life benefits of intervening. And you can see that after a certain age group here, the damage has already been done. In fact, from intervening at this stage here, past this age group here, usually in mid-60s, it becomes actually futile. So make sure that if you're going to intervene in modifiable factors, it's got to be low enough, and don't leave it too late. Okay, so we've moved on to genomics and biomarkers. Obviously, I've had a long career working in genomics and biomarkers, so I see myself as a poacher come gamekeeper very much. I think there's a lot of technocrats who want to sell you their technology, but there isn't an evidence base. So let's look at the successes. What have we learned from genomics that's useful in your clinical practice? Well, in fact, there's three really good paradigms here that illustrate this issue well. There's the APC mutations, which are very useful in colorectal cancer. For example, if you have an APC mutation, there's a 90% risk by 40 years of age, you'll have a colorectal cancer. So that's pretty spectacular. Secondly, there's E-cadherin mutations here, which are, again, a rare mutation. They've got a moderate risk factor. The penetrance, even if you have an E-cadherin mutation for hereditary diffuse gastric cancer, varies between 50 to 80%. So even if you have the mutation, you still may not get your cancer later on in life. But it's a modifier, it's a factor which actually may lead to people having a prophylactic gastrectomy. But obviously, it's a heck of a big intervention to make in someone who may have a 50% risk of getting a cancer in a lifetime. And this is where we are. So this is colorectal cancer, E-cadherin for diffuse gastric cancer, Barrett's esophagus. We know we have what we call genetic drift, where there's multiple small genes that drive a small predisposition. In the last count, we were up to 32 genes, but it's quite likely that when you look at genomic factors, we're dealing with at least 100 genetic risk factors, each of which has a very tiny contribution. So genetic screening for Barrett's risk factors isn't worth doing other than understanding the pathophysiology. What we have learned from the genetics is obesity drives the disease an awful lot due to abnormal inflammation and cytokines. And we've also learned there's developmental changes where people have what the Dutch in Belgium's called the acid pocket hiatus hernias developing. So some people have a susceptibility to that. If you look at biomarkers, in fact, the evidence is very poor here for blood biomarkers as opposed to doing genomic testing here. This is the only really validated biomarkers: alpha-fetoprotein for hepatocellular cancer, C19.9 for pancreatic and biliary cancer, CA for follow-up rather than diagnosis of people with colorectal cancer, and c-KIT for GIST. Apart from that, there isn't anything, and there's no validated trials to use in clinical practice. So if I move on to the third aspect of technology, you'll hear a lot about technology, and I've worked in the Middle East, and the technology that's being pushed on people to try and get tests and investigations done is phenomenal, but there isn't a strong evidence base. So in this one slide about technology, in fact, what we know is it's got to be very simple and generalizable. So here's an idea of a technology that's absolutely superb and certainly changed the way I practice gastroenterology. If you use fecal immunochemical testing prior to suggesting colonoscopy in populations, the positivity of that test will make people much more likely to actually uptake the subsequent colonoscopy, where if you actually just rely on giving people colonoscopy, the uptake is much poorer. So this should change your practice. If you have patients in doubt, always give them the testing here because you're going to get a much higher uptake. Where I want to emphasize here is obviously we've heard a lot in this conference about AI and the idea of multi-omics here. That is certainly something that's coming, but it is not there yet. And I personally have seen no reliable data that that can be currently used in clinical practice. But actually, if you Google all of these techniques, you'll find multiple clinics throughout the world who are actually offering these techniques. But this is not something I want to recommend at this moment in time. So the point of this is keep it simple and generalizable. Technology like fecal immunocytochemical testing has already made a difference, so use that if you're going to get something from new technology. Cancer interception. So this is where I'm going to spend a wee bit more time. This is where there's really very powerful data of something that should change your practice. The idea is if this is someone moving down a chronological age and they actually develop abnormal biology, you can actually intercept some of these problems. And this works very well for the adenoma colorectal cancer syndrome here. So you could intercept and bring them back down to a normal pathophysiological curve. In fact, there's really nice evidence now. We have several decades of really powerful evidence to show that if you actually look at normal populations who are unscreened and you actually go into populations where there's regular screening and removing of polyps, so this is people who had no adenomas, this is people who had adenomas, you can see you can actually change lifetime curves of people dying of cancer. So if you have no adenomas detected, you'll have a low curve. If you've got adenomas detected and have subsequent follow-up, you can actually change the amount of deaths here too. So we know that there's powerful evidence to suggest early intervention with colorectal polyp adenoma removal is important. And this just further illustrates the point from more recent papers here. In fact, this is a paper from New England Journal showing that, in fact, if you look at people who undergo colorectal cancer screening in polyp removal, not only do you pick up adenomas, but actually you can pick up early cancers, and you pick up a lot of early cancers here. And so this is a screened population, and actually a few years into the screening test, in fact, the number of cancers dropped down, where if you're in the unscreened population, obviously there's less cancers detected which are asymptomatic, but actually they present much more later where they're much less curable. So you can intervene with adenomas, but you can also pick up early cancers that you can cure as well. And if you look at this paper, again, very recent within the last 12 months, looking at the incidence of colorectal deaths here. So this is screen detected populations. This is non-screen detected populations. So you can see the longevity and survival is very appreciably different. So one thing I'd like you to get from this is please, please, please encourage all of your patients to undertake colorectal cancer screening. It's something which is applicable throughout the world. It's almost a no-brainer. And if you detect some resistance, do employ fecal immunohistochemical testing because it will be extra evidence to convey to your patients. So let's look at the upper end of the GI tract. So the evidence is very powerful, colonoscopic screening. What about the upper GI tract? Well, this is a paper where Paul was involved in. I was involved in too, but I also want to thank the chief investigator, Hugh Barr, which was one of the largest and longest follow-up trials in gastroenterology, certainly one of the biggest endoscopic trials of Barrett's esophagus. And what we're doing is, could 2-year screening of endoscopy, upper GI endoscopy in patients with known Barrett's esophagus decrease your risk of colorectal cancer? And you can almost not make any difference here between the endoscope endoscopy at time of need and 2-year surveillance here. And actually the curves are absolutely identical, showing that, in fact, the evidence to show that Barrett surveillance, even at the earlier screening interval of 2 years, rather than the slightly longer 3 years, actually doesn't give you any added value there. So that tells us something very powerful. So in the lower GI tract, because you've got discrete adenomas and you can pick up abnormalities, it makes a big difference. Where you've got a field defect, it's no longer a clonal change. In the upper GI tract, it's a field change. It's much more difficult to detect. Endoscopy is much less valuable. With the one proviso is that, in fact, if you look at, so this is in a UK population, some Canadian site also involved. If you actually look at endoscopic screening in squamous cancer, here's a paper in China that shows it's actually quite different. This is a very, very high incidence area. I should say that adenocarcinoma in the UK population is one of the highest areas in the world for adenocarcinoma. Scotland is the epicenter of adenocarcinoma, but still, it's not prevalent enough to make screening worthwhile, where squamous cancer in parts of China is incredibly high, 10 times higher the rate of squamous cancer and of the esophagus than it is in the highest areas of Scotland for adenocarcinoma. And screening here makes a very big difference. So this is the screen population, the red curve here, and you can see that a very marked difference in lives saved in cancers prevented versus the non-screen population. So the take-home message here from the upper GI tract is endoscopy is probably very good for squamous cell cancer screening in high-risk parts of the world, such as Southeast Asia, but not very good for adenocarcinoma prevention in the upper GI tract. So let's look at chemo prevention. Chemo prevention is a very difficult road. It needs a long-term study, and selecting the right agent. Aspirin is by far the best agent, better than anything or any other combination. I won't go into the data for that. Choosing the right dose of aspirin is very important, and actually the disincentives for researchers to do this, because in fact, it's a very long-term project. It needs 10 years, 20 years to be able to work. So I'm going to start with colorectal cancer. So this is from a friend who I deeply respect, John Byrne, Sir John Byrne, who did groundbreaking work with Lynch syndrome, where people have hereditary colorectal cancer. And the purpose of these 4 boxes here is this is looking at the intervention of aspirin, 300 milligrams twice a day, and the number needed to treat works out to be 1 in 63 over 10 years, which is actually very acceptable indeed. And the side effects of low-dose aspirin, in medium-dose aspirin, are very acceptable too. So this is looking at the intention to treat curves here. So this is CRC cancers. In all cancers, you can see that with aspirin, 300 milligrams twice a day, you actually get a better effect in colorectal cancer than all cancers. But this is intention to treat. Not all of these patients will have had a very long aspirin. If you actually look at those who were treated with a minimum of 2 years as per the protocol, you can see the curves here are wider here than there, suggesting that actually when you do sub-analysis, you get a better response with aspirin when you actually take it. And to a lesser extent, that also happens with all cancers as well. So very powerful evidence to say if you have hereditary colorectal cancer, Lynch syndrome, intervening with aspirin does make a big difference. A number needed to treat is very acceptable. This is our paper from the Lancet, and actually I should say that we're following this cohort and we'll be submitting an update. So this is the interim results from 2018, and this was from the Barrett's population. Again, Paul was involved in this in a major way, which I'm very grateful for. And the purpose of all of these curves here are, these are high-dose PPI, so this is a blue curve, low-dose PPI, the green curve, high-dose PPI plus aspirin, 300 milligrams or less, depending on the tolerable dose, and low-dose PPI plus aspirin. And you can see that the lowest curve here is this one here, high-dose PPI plus aspirin, which is the combination of very strong acid suppression and aspirin itself is very effective in decreasing your risk, not only to Barrett's dysplasia, adenocarcinoma, but death too. Because there wasn't enough numbers, we knew that at the start of this. This is still a very rare event for the reasons I've alluded to, is that we needed 3 simultaneous endpoints here. But nonetheless, if you take the combination, a very significant effect. And the next most important out of this is high-dose PPI. So the evidence from this is that taking very profound acid suppression is very important. And actually, if you take the profound acid suppression with low-dose aspirin, you get a beneficial effect there too. And just to make the point here with low-dose aspirin, this is a forest plot. This is those who weren't taking aspirin and aspirin. This is those who reach the coterminous primary endpoints, which are, if you take aspirin for just 2 years, you decrease your risk of getting your primary endpoint by 6 months. If you take it for 4 years, you double that. And this goes on until if you're taking it for 8 years or more, you're you're delaying your primary endpoint of one of these 3 things by 2 years or more. So a very significant delay. So I want to emphasize Helicobacter as a very powerful aspect of chemoprevention. So we've talked about aspirin, now we talk about acid suppression here too. And if you look at Helicobacter prevention, not only can you decrease the risk of cancer, you can actually decrease precancerous risks here too. And this is a slide I'm very grateful to Paul for, which is actually, if you look at the forest plot and look at this over many studies, you get a very profound difference with Helicobacter. Here's a forest plot here showing a very sizable reduction. But I want to emphasize the caveat here is this is in a very high risk region part of the world in Asia where Helicobacter causes more cancers than it would in the West. But still the number needed to treat here for cancer prevention is 1 in 228. And since you're only having an intervention for 7 days as opposed to chemoprevention with aspirin, 1 tablet for multiple years, this is actually a very acceptable number needed to treat. So if I come on to the very last part of my talk, which is what can we actually do now? So what I've summarized, technology is not really there apart from fit. We've talked about demographics. We've talked about genomics and how that gives you some aspects, but not enough information, biomarkers. We've talked about chemoprevention and endoscopy, the value of that. What can we actually do now? Well, actually, one thing I've been fascinated with is the idea of actually how we can look at long-lived populations, because the 2 major driver factors of long-lived populations are cancer and vascular deaths. And there's 5 parts of the world that increase all of that, where there's more people living over 100 years of age. And there's been some really beautiful studies within the last 12 months showing the food substances, and I've taken most of them out here in green, which are highly beneficial, versus the bad food substances you know about, the saturated fats, the red meat, etc., high salt diets. And we've summarized all of this in a book. I've just put this down here to be devilish. Insect protein probably does have an advantage, apart from chitin, which can cause allergic responses in people who are sensitive to prawns. But apart from that, insect protein probably should be on this list. So the issue of doing all of this is change requires education to change your beliefs, change your values, then your attitudes change, and then in the end of the day, you change your behavior. So this is what you need, is you need a cycle of change here. And what we have done is with AI company Healthinix in the UK, we have looked at the role of anti-inflammatory diets using this mnemonic of space, selenium, phytochemicals, vitamins A, C, and E. And what we've done is we've taken some blood tests and symptom questionnaires. We've had AI to work out the perfect diets for these individuals according to their requirements and preferences, and actually given them the remote support. So that's already in place. And I think that sort of use of AI is now becoming commonplace. So I want to just conclude with my last slide here is what can we actually say about AI cancer, the cancer prevention in the GI tract. It's simple A to E. Alcohol, minimize or abstain. Tobacco, absolutely zero tolerance of tobacco. Blood testing. Genetic testing is good if you've got a family history, but biomarkers are not there yet. Chemoprevention, aspirin, certainly for the colon, maybe for Barrett's, but we'll have information that a year from now. Helicobacter, certainly yes, certainly in South East Asia, and certainly if you have a family history of gastric cancer. I haven't mentioned GLP-1, but there's actually very powerful evidence to suggest that they actually change an awful lot of metabolism, including cancer and cardiac, that might be, so you might be hearing more about that in the next 12 months. Here are the aspects of your diet you should change now, the 5 rules of 5, protein, prebiotics, probiotics, pulses, plenty of water, healthy fats, 5 fruits and vegetables. Keep you 5% of your diet of less than sugar, less than 5% of grams, and endoscopic screening in high-risk populations in particular regions, particularly colorectal cancer globally and upper GI tract for lower GI. So I want to thank there and thank you very much for your attention.